as a master's program in public health, and there are other programs coming in the way. So as you can see, we're putting quite a lot of effort in here on aspects that have to do with healthcare. My colleague, Professor Habib Al-Safar, who is the Dean of the College of Medicine, does quite a lot of effort in actually bringing synergies into this field. And we work quite closely with the Department of Health of Abu Dhabi, as well as the wider health providers community in the country. I'm sure this conference will be highly informative for everyone. And I would like to extend a very warm welcome to anyone who joined us, particularly from outside the UAE, and particularly if it's your first time. You came kind of at the wrong time. If it's your first time, the great weather is normally sometime around December. All right. So right now we are just warming up for the summer. Okay, this is just the beginning for the summer, but nonetheless, the evenings are still bearable. So I really wish you all a very successful conference, and those of you who are coming for visit, I wish you a wonderful stay. And before I close, I would like to thank my colleague, Dr. Abdul Adam, and all the team that are organizing this conference. I organize many conferences, and I do know and appreciate the enormous effort that it takes to organize such events and the determination that goes into it. When we are attending conferences, we can only see the final product. But this final product goes through so many stages, which I am sure you all appreciate. So I'd like to thank you all, and I'd like to thank Dr. Abdul Adam and all the conference organizing committee for, I'm sure this will be a wonderful conference. Thank you all. Thank you.
So thank you, Professor Koteri. It's all good. Thank you so much for your time and your valuable remarks. Now we will hear some insight from the member of the organizing committee who has worked very hard, as Professor Koteri mentioned, who played a vital role in shaping this conference. So first, I would like to invite Professor Marwan Sabah to the stage. So please welcome him with your round of applause.
Welcome to the 9th International Conference on Alzheimer's disease in the Middle East. I thank you for participating and look forward to a productive exchange and dialogue amongst our academic and scientific colleagues and to advance the interests of the region. I'm Marwan Sabah, Professor of Neurology and Vice Chair for Research at the Barrow Neurological Institute. This program does not happen without a tremendous amount of work from a lot of people. I'd first like to take a moment to thank some specific people. First is Professor Robert Friedland. Professor Friedland, who will talk today, this is his brainchild. He actually convened the first, second, third, and fourth International Conference on Alzheimer's disease in the Middle East before our organizing committee and I joined for the fifth. So I thank you for your vision and bringing this forward. This is 25 years of work that has had the 9 conferences. Second, I'd like to thank my dear friend and colleague, Professor Abdul Adam. Professor Abdul and I know each other for 40 years. And I thank him because he was the big spirit behind getting Khalifa University working with us. And so thank you, Professor Abdul. Third, I'd like to thank Dr. Hanan Sheikh Ibrahim, who brought us a lot of speakers. And thank you for your ideas and energy. And fourth, I'd like to thank Dr. Suhail, who really told us how to manage the medical environment in UAE. I'd like to thank our academic partners, Barrow Neurological Institute. My professor and chairman, Professor Brad Reset, is going to give one of the keynote speakers today. He was supportive of my idea of bringing a conference here. And I would like to thank the Dean, Provost at Khalifa University for their support of bringing this conference here. I'd like to thank the sponsors, Lilly, Biogen, ASI, Life Molecular Imaging, and Anavex for their underwriting of the conference. I'd like to thank MCO for their work. Particularly, I want to thank Arlene, who got on a lot of conference calls and a lot of WhatsApp chats for hundreds of hours, and so thank you for that. Why are we here? The 9th International Conference on Alzheimer's Disease was founded by Professor Robert Friedland, which was intended to increase dialogue between the different parties, scientific leaders, thought leaders, key opinion leaders, physicians, clinicians, and scientists. That has been achieved. But when we move forward now, one of the focuses will be in identifying regional issues that are affecting the region. How can we come up with a comprehensive regional solution that can be beneficial to many countries and many physicians in this area? I know that a lot of you who are participating today have the ear of your healthcare authorities who can help influence policy that can help advance healthcare, whether it's a diagnostic, a therapeutic, a biomarker, an imaging platform, whatever it is. This is the conference that allows us to have these conversations and identify regional interests, regional issues, and potential solutions. So with that, I thank you again and welcome.
Thank you so much, Professor Marwan, for your thoughtful remarks. So now we will move forward to hear from some remarks from Professor Dr. Abdul Adam from Khalifa University. So please welcome him.
Good afternoon. Welcome, everybody. I just want to reiterate what Professor Marwan mentioned. In the first place, I want to thank the committee, with Dr. Friedland, Dr. Marwan Sabak, and Dr. Hanan for tremendous effort to make this happen. Secondly, I want to really thank Khalifa University for all the efforts, starting from Professor Kuteri, who is with us here, but behind the scenes, he was the one who really helped us a lot to bring the conference here. I'd like to thank the whole leadership of Khalifa University, the president, the provost, and all the associates for making this possible. I also want to thank very much the team in Khalifa University who made this happen. I mean, there are different departments, who really work together to really make this conference happen. I can mention two names at least, Lara Yaqub and Iyad Zerba, who really did a lot of work and helped us with this thing. I mean, it seems very simple, but there are so many small details and so on. And also, I would like to all the delegates who are coming from abroad, or for all the visa permissions and so on. So I hope you tolerate that. And we are lucky we got almost all of our speakers are here. So that would be excellent. I wish all of you who are coming from outside the country or from the UAE a very nice stay. And I hope we'll have a very fruitful discussions and debates, and maybe some suggestions to the health institutions we have in this country. Thank you very much.
Thank you, Professor Abdul Adam, for all your efforts to organize this conference along with your other team members. Now we will move towards next committee member, Professor Robert Friedland. So please welcome him to the stage.
Thank you. I'm very pleased to congratulate Dr. Sabah, Dr. Adam, and their colleagues in the remarkable success in making this meeting take place. in addition to the previous meetings which we heard about. It's really a difficult thing to raise money and to bring people together. And it has been remarkably successful and survived quite a long time and survived enormous challenges regionally and internationally. I'd like to tell you briefly the story of how this happened. Really, in the early 90s, I was working at Case Western and I met a man whose wife had Alzheimer's disease. And he was the second wealthiest man in Ohio. With great difficulty and against his best interest, he really didn't want to do it, but he gave Case Western Reserve University some money for research. And we ended up studying the genetics of Alzheimer's disease in Arabs who reside in Israel. We got an NIH grant, which lasted for 9 years. We published many papers, which many of you know about, and we did not find an autosomal recessive gene, but we did study environmental risk factors, including diet, obesity, exercise, hypertension, education, smoking, and others. And I'm sure during the conference we'll have time to discuss the relevance of these environmental risk factors for this disease in this community. I have a little story which illustrates what the state was like at that time in the 90s. I was in Qatar and I was seeing a patient and I was trying to raise money from the Minister of Health, who seemed to think it was a good idea to study the population of older persons in his country. And the attractiveness, it was in part, it could be, I thought, the only environmental or epidemiological study ever where you study absolutely everyone, because there aren't that many people in that country who are over 65. We were not successful. And they thought it might help if I was interviewed by a newspaper, the local newspaper in Doha. So I was interviewed about the disease, and then the article was published and it was translated for me. And in the article it said, "Fortunately, Dr. Friedland says that Alzheimer's disease does not occur in this country." And of course, it didn't say that. And in conclusion, one might ask, or people might ask, what am I doing here? I was in Cleveland and later elsewhere at NIH and so on. I'm working on Alzheimer's, and how did I end up caring about this? Caring about the question of enhancing an awareness of Alzheimer's disease in this community. How do I end up caring about how people are talking to each other between these various countries? And of course, it's a big topic and I don't have any more time, but I thought I can summarize this with a quote from the United States Vice President. He said, "You love your family, and then you love your neighbor, and then you love your community, and then you love your fellow citizens in your own country, and then, after that, you can focus and prioritize the rest of the world." So to this, I say no. You don't have a hierarchy of love and concern and compassion, because after all, we're all part of the same family. And I look forward to our discussions so we learn even better to work together and to solve these very serious problems, which are our responsibility. Thank you.
Thank you, Professor Robert Friedland. And we appreciate all your scientific contribution towards the treatment of the Alzheimer's disease and understanding this disease. Next, we will move forward for Professor Hanan Sheikh Ibrahim to have her insights. So please welcome her on the stage.
Yeah. Good afternoon, ladies and gentlemen, esteemed scientists, innovator, and change makers. Everyone in this room is change makers because we have changed our perspective to a new era of Alzheimer's. We've moved from a terminal disease into preventable disease, and we need you, someone like you, academic neuroscientists, to team up with us, clinicians, to build up a better pathway. So we are in the right place. We are in the visionary United Arab Emirates, where science meets ambition, and the future of Alzheimer care is being reimagined. So in the region, we have expected rise to 1,000 incidence rate per year of Alzheimer, according to Lancet. And you know that all over the world, every 3 seconds, someone is dying from Alzheimer's. So if we put a lot of effort in COVID-19, it was like a pandemic. I would call Alzheimer's an epidemic at least. But the difference is it didn't kill you right away, it killed you softly. So that's why we did not have the reaction. So that's how important it is. And even for us women, we took care of breast cancer prevention. We did very well in minimizing the burden of the disease. But did you know that women can die from Alzheimer's more than they can die from breast cancer? And we haven't done enough even for women. And we know that every 3 people who have Alzheimer, 2 are women, and 1 is only man. So that we haven't done enough. Now, unfortunately, the cost of Alzheimer. Anybody is familiar with the budget of France, which is one of the richest country in Europe, Germany and France. Anybody's familiar how much? It's like $855 billion. It changed, per year. But did you know how much Alzheimer's state cost? So this is the WHO. In 2021, it was around 1.3 trillion, and it's expected to rise to 3.8 trillion. So that's another reason why we're here today. The other reason is, as I said, it's one of the top 10 cause for death. This 5th can be changeable between year and year. I know it was moved sometimes to 6 or 7 because of COVID, thanks to COVID, but now we might recalibrate that after COVID is gone, unless we have another, epidemic or pandemic. So let's talk about the MENA region. It's the fastest growing number of people with Alzheimer in the world. And as I said, the cases are expected to increase by greater than 1,000. And this is the map, not for COVID, for Alzheimer incidents per the Lancet. And, you can go into the epidemiology. The reddest area are the hottest area for this volcano, and we are on the reddest part and this is, we're here in the MENA region, where the GCC area, and this is where, UAE stands, and the expected rise. And there's another also publication, by Metwally. It also span all of the region, and it says currently they're expected 3 million in the Middle East, and the prevalence, it's 2.3 below 50. But it can rise up to 18 for Arabs, above 80, and 2 out of 3 patients of Alzheimer, the same as the global number. 2 out of 3 are women, unfortunately, and they expected this to rise to 14 million. So that's how big it is, and that's, we haven't done enough. This is just an eye-opener. I welcome you here, people who are coming from abroad, and I wanted to thank everyone from organizing committee, our colleague, Dr. Marwan, Dr. Abdul, Dr. Rick, and Dr. Finlander. So for all those help, I like to thank also Khalifa leadership, and I like to thank stakeholder and audiences for having such passion and attention to come at this time on Friday weekend. And thank you so much. I'll see you soon for Women's Cognitive Health.
Thank you, Professor Hanan, for sharing your insights. And we agree that Alzheimer's disease is really a global challenge. And I'm very hopeful that we have a very good pipeline of brilliant speakers today, so we will benefit from them. So let's begin with the session one now, the scientific session. And thank you all again for all the speakers and their thoughtful and inspiring remarks. So to start with the first session, which is the Breaking Science and Epidemiology, I would like to invite our moderators for that session, Professor Abdul Adam and Professor Robert Friedland. So I would now invite you to come to the stage, please, and I will hand over the stage to you guys for the next session. So thank you so much again.
I'd like to introduce our first speaker. We are having this first session on breaking science and epidemiology. Our first speaker will be Professor Jose Luschinger, who could not make it here today, but we have his talk. So it will be online. Professor Jose is a Robert F. Lloyd Professor of Medicine and Professor of Immunology at the Columbia University of Medical Center. He is a director of the Center for Research on Aging and Quality of Life and Vice Chair for Clinical and Epidemiological Research in the Department of Medicine, Columbia University. He has been conducting research in risk factors and prevention of Alzheimer's disease and AD-related dementia for 25 years, including observational studies and clinical trials. He is the editor-in-chief of the Journal of Alzheimer's Disease and Associated Disorders. We'll listen to his talk. So just sit in now. Thank you very much.
Good afternoon. Thank you for the invitation to speak at this conference. I'll be speaking about diabetes and Alzheimer's disease. First, I need to make some disclosures. I receive royalties as editor of the book Diabetes in the Brain. I receive a stipend from Wolster Kloof as editor-in-chief of a journal, and I'm a consultant to Novo Nordisk. Also, my research is funded by the National Institute of Aging in the United States, for which I'm very grateful. And I have to acknowledge that I have many collaborators that have led to some of the evidence that I'll be showing today, and I can't acknowledge them all, but just want to acknowledge that this work is done with many collaborators. So the organization of my talk is as follows. First, I'll give a little bit of background. Then I'll show observational data about diabetes and cognitive impairment. Then I'll talk about mechanisms. And lastly, I'll speak about translation. So let's start with some background. Worldwide, there are 822 million people who had diabetes in 2022, according to the World Health Organization. And that's about 14% of adults, meaning persons 18 years and older. In the United States, the 34.2 million people had diabetes in 2020, and that's roughly over 10% of adults. And in the United Arab Emirates, almost 1 million persons had diabetes in 2021. That's out of about 8 million, which with a prevalence of just over 12% in adults. And this is according to the International Diabetes Federation. Most importantly, in the group that is most at risk for cognitive impairment, people over the age of 60 or 65, the prevalence of diabetes is much higher. And actually, if you count pre-diabetes, probably half of the population over the age of 65 years and older have pre-diabetes and diabetes. So this is a huge public health problem and very concerning in its relation to cognitive impairment. Now, I think it's important to review the natural history that leads to type 2 diabetes, because this has to be taken into account during my talk. So it is thought that for type 2 diabetes in particular, the main risk factor is increased adiposity or obesity, which leads to insulin resistance and high insulin levels, which eventually lead to elevations in glucose in the range of prediabetes when the pancreas cannot keep up with the insulin resistance, and type 2 diabetes when it's a more severe glucose elevation. But it's important to remember that this is accompanied by the metabolic syndrome, that is high blood pressure, inflammation, and dyslipidemia. And this is important because I only have 30 minutes for the talk, so I have to really focus mostly on diabetes, and it's going to be very glycemic centric, but it's important to remember that glucose elevations and diabetes are accompanied or preceded by this phenomena, meaning increased adiposity and related factors, high insulin levels, and also the elements of the metabolic syndrome. So please take this into account as I go along in my talk. Now, I'll start with observational data on diabetes and dementia from a study in New York City called the Washington Heights Inwood Columbia Aging Project, in which I was a collaborator. The principal investigator of this study for 30 years has been Richard Mayo, who's the head of the Department of Neurology at Columbia. And this is data in about 2,000 people who were 65 years and older at baseline, had no dementia at baseline, and were followed prospectively. And diabetes in this cohort, which was ascertained by self-report or use of diabetes medications, we didn't have biochemical evidence of diabetes. Diabetes was related to around a 70% increase in the risk of Alzheimer's dementia, about a tripling of the risk of vascular dementia, and then if you consider all dementia, about the doubling of the risk of dementia. It's important to consider that this study is from the early 2000s. We didn't have biomarkers, so the ascertainment of cognitive syndromes was based on medical history, if you will, in questionnaires, and not really on brain imaging or any other type of biomarkers. Now, when we adjusted for vascular risk factors, this association with Alzheimer's dementia persisted, but there's always the possibility that some cases of vascular dementia are misclassified of Alzheimer's dementia. So a lingering question in the field has always been, since diabetes is a known risk factor for stroke and cerebrovascular disease, is the association with dementia all vascular, or is there Alzheimer's pathology in play as well? Now, we did look at diabetes and prediabetes defined by hemoglobin A1C. This is following American Diabetes Association criteria in a younger cohort of 600 people with an average age of 59 years. The previous slide was in a cohort with an average age of around 75 or 76 years old. And you can already see, this is cross-sectional data, that in people with diabetes have a recall of less words in the selective reminding test compared to people with prediabetes, who in turn recall less words than people with who have normal glucose tolerance. And there's also differences in non-memory tests. For example, a test of language, a verbal fluency test, and a test of executive function, the color trials too. So already in late middle age, you can see evidence of diabetes and prediabetes being associated with lower performance in both memory, but also in non-amnestic cognitive domains. Now, the question is, what are the mechanisms? The slides that I showed before, I would say, are representative of many studies that have done across the world, and I think there's an acceptance that diabetes is related to an increased risk of dementia and an increased risk of cognitive impairment overall, but the mechanisms are not clear. And I think a good question is whether diabetes is associated with Alzheimer's disease, meaning plaques and tangles in the brain. And this is a study from Japan, from a cohort called the Hisayama study, in which people had donation of the brains and underwent autopsy, and several measures of glycemia and insulin resistance that were taken 10 years before death were related to Alzheimer's pathology in the brain. And so here in the first graphic to the left, you have 2-hour post-load plasma glucose. Then you have fasting insulin in the middle, and HOMA-IR, which is a measure of insulin resistance that uses both fasting insulin and glucose. And what you see in this study is that actually in higher levels of glucose, higher levels of insulin, and higher insulin resistance were related to higher odds of Alzheimer's pathology in the brain. So this is very nice and very clean, but it is important to point out that there's been maybe between less than 10 studies that have looked at this in the world, and most of them have not shown this association. Most of them have shown that there is no association between diabetes and Alzheimer's pathology in the brain. The Hisayama study, this study that I showed you, and that curiously, a study of Japanese Americans in the United States are the only two studies that I can remember that have shown an association between diabetes and Alzheimer's pathology. Now, fortunately, we're in an era where we have biomarkers, and we don't have to wait for people to die before we can do an autopsy and look at neuropathology. So now we're in the era of biomarkers, and we can look at this in vivo. And this includes looking at cortical thickness and brain volumes in regions of interest, and using brain magnetic resonance imaging, using amyloid PET scans. Here you can see in red the amyloid that's accumulating mostly in the frontal lobes. Now we have tau PET as well, which actually shows the distribution of tau beginning in the temporal lobes and spreading posteriorly. And of course, we can also image cerebrovascular disease. Here you can see white matter hyperintensities in MRI. So we're in an era of discovery because of the availability of imaging, but also non-imaging biomarkers. And so this has led to a new framework in Alzheimer's disease, which is to define outcomes by biomarkers and not by clinical syndromes, like in the first slide that I showed you from the YCAP study. And in this framework, people who have evidence of high amyloid in the brain are said to be in the Alzheimer's continuum, and then they have both Alzheimer's, high amyloid and tau, they're said to have Alzheimer's disease. And then if people have high tau or high neurodegeneration, but have low amyloid, it's called non-AD pathologic change. And as many of you know, the typical amyloid hypothesis is that accumulations of amyloid lead to accumulations in tau, which lead to neurodegeneration and to cognitive impairment. But the use of biomarkers can help us look at alternative pathways, which is what you see in these other boxes. And so this is a study from a cohort in Rochester, Minnesota, in the Mayo Clinic that examined the association of neurodegeneration ascertained by fluorodeoxyglucose PET and amyloid PIB in relation to diabetes in a population that was around 79 years of age or so. And the people with diabetes had lower uptake of FDG in areas that are typically affected by Alzheimer's disease compared to people without diabetes. And so the authors concluded that diabetes is associated with neurodegeneration that seems to follow a pattern of Alzheimer's disease. But when they looked at amyloid burden, which was ascertained by PIB-PET, actually, although the people with diabetes had a slightly elevated levels of amyloid because of a p-value that did not reach the threshold of 0.05, they concluded that there was no association between diabetes and amyloid. So their conclusion was that while there was no association between diabetes and higher amyloid levels compared to people with diabetes do present a pattern of neurodegeneration that is similar to the one presented in Alzheimer's disease. Now, we looked at the same thing in a middle-aged cohort with an average age of about 64 years with verbetamine PET, which you can see here on the right. And to our surprise, people with type 2 diabetes actually had the lowest prevalence of high amyloid in the brain compared to people with undiagnosed diabetes and people with pre-diabetes who had the highest ones, the highest level of high amyloid in the brain. And so, we were perplexed by this. So we looked at other associations. So actually diabetes was associated with thinner cortical cortices, which is suggestive of neurodegeneration. It was associated with a higher volume of white matter hyperintensities and with lower cognition. So all the associations went in the expected direction, except the amyloid. And when we examined whether medications for diabetes could explain that, we found that indeed, although this was a cross-sectional study, use of diabetes medications, which were 80% metformin, were associated with lower levels of amyloid. And there's at least another study from the Alzheimer's Disease Neuroimaging Initiative that showed that people with untreated diabetes had a faster time to dementia compared to people with treated diabetes. And then they looked at Alzheimer's biomarkers in cerebrospinal fluid, that is using a lumbar puncture, and they found that people with untreated diabetes actually had higher levels of tau and lower levels of A beta of 42, which is typical of an Alzheimer's pattern compared to people with treated diabetes. So a hypothesis is generated by these findings that diabetes treatment may actually somehow improve the clearance of amyloid. And in this cohort as well, the most commonly used diabetes medication was metformin, which is not uncommon because metformin is the first-line treatment for Alzheimer's disease. So now, how does this translate into treatments? So I would say that there's three hypotheses to review. One is that better diabetes control can lead to better cognitive outcomes in persons with diabetes. The second one is that diabetes prevention can lead to better cognitive outcomes. And the third hypothesis is that diabetes medications, particularly insulin sensitizers, can be repurposed for the prevention and treatment of cognitive impairment. So I'll be talking mostly about metformin because it's what I have experience with. There are studies that have looked at PPAR gamma agonists, but PPAR gamma agonists have been demonstrated to have adverse cardiovascular effects, including increased risk of stroke. And they have a black box warning in this regard in the Food and Drug Administration in the United States. So actually, they're not very commonly used anymore for diabetes treatment or in people without diabetes. And of course, the GLP-1 agonists, which are all the rage right now. There's ongoing clinical trials of GLP-1 agonists in Alzheimer's disease. I won't be talking about this because of time constraints, but I'll be showing you a little bit of data about these three hypotheses. So how about diabetes control and cognitive outcomes? So this is a study that we conducted more than 10 years ago that originally was a randomized trial of a telemedicine intervention to improve diabetes control compared to usual care, global cognitive performance measured with a tool called the CARE diagnostic was a secondary outcome. It was not a primary outcome in the trial, but I had the privilege of being able to analyze this data. And what was shown was that after 5 years, people in the usual care group had more cognitive impairment than people in the telemedicine group. The CARE diagnostic measures increased impairment, meaning that higher scores mean more impairment. So here you see that at the end of the study, there was a higher score in the care diagnostic on average than in the telemedicine group. And we did a mediation analysis examining whether this could be explained by improved blood pressure control or improved lipid control or improved glycemic control. And what we found was that improved hemoglobin A1C seemed to account for this effect. But again, this is an ad hoc analysis or a secondary analysis in a clinical trial in which the care diagnostic was not the primary outcome. So that's important to say. And this is an observational study, I believe from Hong Kong, if I remember well, that was published in JAMA Network Open that was observational, but made some adjustments to be able to, look at the data in almost a randomized fashion, but it was not a randomized trial. And they looked at, they compared people with usual care for diabetes and people with a multidisciplinary intervention to improve diabetes. And what they observed was that the probability of developing dementia was lower in the improved control group than the usual care group. So, it's difficult to have randomized clinical trial data to examine whether dementia and cognitive impairment risk can be improved in people with diabetes because it's unethical not to treat people with diabetes as best you can nowadays. So it may be that this observational data or data from using cognition as a secondary outcome in existing diabetes randomized trials is the best data we have. But it suggests that better diabetes control leads to better cognitive outcomes. Now, how about diabetes prevention? So the first study to examine whether diabetes could be prevented was the Finnish diabetes prevention study. And the results were first published in the New England Journal of Medicine, but here we have the long-term follow-up results of the study. And it was a study of an intervention which was a randomized control trial of an intervention that was basically diet and exercise that resulted in weight loss versus control. And actually the risk of diabetes in the control group was higher than in the intervention group, even after 8 years. And so what you see here is a faster time to diabetes in the control group. And so with support from the American Diabetes Association, who generously gave us a grant to do cognitive assessments in this clinical trial, we looked about 12 years after randomization whether there were differences in the trail making test and in the SARAD cognitive battery. And of course, these tests were done in Finnish, and the study was based at the University of Helsinki. The bottom line is that we found no difference in cognitive performance between the groups. And, please bear in mind that all of the people in this clinical trial were at high risk for diabetes at the beginning. So there were no people probably with normal glucose tolerance. We examined a similar question in the Diabetes Prevention Program outcome study, which was conducted in the United States. And this was originally a trial of 3,000 people who were randomized to lifestyle interventions similar to the Finnish study, but also metformin and placebo. And after 3 years, it was observed that people in the lifestyle arm had more than 50% less risk of diabetes than in the control group. And in the metformin arm, there was about a 30% decreased risk of diabetes. And these are the results after 10 years of follow-up, where you can see that glycemia after 10 years was still better in the lifestyle arm compared to the placebo arm, but glycemia was much better in the metformin arm, not surprisingly, I would say. So we also did cognitive assessments in this study 12 years after randomization. And again, these are the different tests, the Spanish English learning test, the digit symbol substitution test, animal fluency and letter fluency. And you can see the bars of the different arms. They're almost identical, suggesting that there was no difference. We were disappointed by this, of course, but again, we have to remember that all people in the diabetes prevention program originally were considered to be at high risk for diabetes. Something similar to what we would call diabetes. Nowadays, there were no normals. Now we continue to follow up these people to see if there's longer term benefits of the interventions. Now, metformin, has been hypothesized to be a miracle drug that not only is effective in diabetes, but it can be an anti-aging and an anti-cancer medication. However, there's been some controversy about whether metformin increases the risk of Alzheimer's disease, both in animal models and in humans. And I don't have time to review all the data, but I'll just acknowledge it and say that this is a meta-analysis published in Diabetic Medicine in February 2022 that examined in observational studies exposure to metformin and the risk of neurodegenerative diseases in people with diabetes. And it found that overall, there was evidence of an association of metformin use with a lower risk of neurodegenerative diseases, including Alzheimer's disease. And this effect was, or this association was stronger for people who had taken metformin for several years. Now, we have conducted clinical trials of metformin. This was a small pilot study conducted in New York City at Columbia of 80 participants, 40 with brain imaging, and people were randomized to metformin, 1,000 milligrams twice a day versus placebo for 12 months. By the way, this was in people without diabetes. Okay, we didn't want them to have diabetes because we didn't want confounding by other diabetes medications. And what we found was that after 12 months, people in the metformin group had a better improvements in performance in the selective reminding test compared to placebo, which was statistically significant, but the secondary outcome, the ADA score, was not significant. And so we're currently conducting a larger phase 2 study that's called Metformin and Alzheimer's Dementia Prevention. We hope to finish it around this time next year in 2026. The study is funded by the National Institute on Aging, and it's a 1-to-1 randomized controlled trial of extended release metformin in 326 persons with amnestic mild cognitive impairment, 55, this should be actually 90 years of age without diabetes. They're followed for 18 months, so the study is larger and people are followed for longer than in the pilot study that I talked about before. They'll have 4 visits every 6 months, and they'll have as outcome changes in a memory test, a free and acute selective reminding test, also in a composite called the ADCS PAC, but also we will be looking at biomarkers of amyloid, tau, and neurodegeneration in brain imaging and in plasma, which is very exciting. And again, hopefully we will have results for this study in the summer of 2026, about a year from now. So we're also conducted this study, which is a study of Alzheimer's disease and Alzheimer's disease-related dementias in the diabetes prevention program that I mentioned before. It's a cohort of 1,700 people with prediabetes or diabetes, all with comprehensive cognitive testing and plasma biomarkers, 800 with MRI and amyloid PET. Unfortunately, this is one of the grants that have been terminated as part of grant termination at Columbia. We're fighting hard to have it reinstated so we can present the results of this important research examining whether people with diabetes have cognitive impairment that is related to Alzheimer's disease or to other mechanisms. So in conclusion, diabetes is associated with cognitive impairment, including mild cognitive impairment and dementia. diabetes treatment, particularly metformin, may modulate amyloid accumulation. And again, may has to be highlighted here. We're not saying that it happens. This is a hypothesis. The mechanisms linking diabetes to neurodegeneration and cognitive impairment remain to be elucidated, and that's why the research that I mentioned before is so important to be completed. Metformin seems safe from a cognitive standpoint for use in persons with diabetes and at risk for diabetes. Metformin is a potential strategy for delaying or preventing cognitive decline, and it's worth examining because metformin is a fairly safe and inexpensive medication. However, definitive research in humans is necessary to establish metformin's cognitive safety and usefulness as a prevention and treatment strategy for cognitive impairment. So in case you have any questions, you can email me, and thank you so much for your attention.
Thank you. Our next speaker is Professor Abdu Adam, who is Department Chair of Medical Sciences at Khalifa University, where he has been since 2020. He's been working to develop a functional neuroscience research, education, and training program. And he will speak to us now about AGES, RAGE signaling, a potential unifying mechanism linking diabetes and neurodegeneration.
Thank you, Dr. Friedland, for the introduction. Of course, after this lecture we had which was done mostly on humans, my talk will be mostly on animals. We're trying to see the linking of. So, okay. Okay. We are trying to find the linking, as we heard from the lecture, that there's still doubts to connect diabetes to Alzheimer's disease or to neurodegenerative diseases. So, what we think is that there might be a link, and we're trying to look at diabetic animals, and we used diabetic animals for long chronic diabetic animals to see if there is a change, because the area is a little bit there's too much there isn't clarity in a lot of things in this area. So let me start by reading that to give you some introduction. Glycation is a relatively slow, natural occurring reaction, and usually this is part of the aging process. And in this process, becomes more accelerated in people who have diabetes, of course, also in animals who have diabetes, because of the hyperglycemia. And glycation, as the word says, is sugar moieties which bind to proteins or amino acids and so on, and create something called advanced glycation end products, which is called age, or called agenes. And this in diabetes has been reported to contribute to several pathogenesis of various complications which are associated with diabetes. So we know one of the major issues in diabetes and even in Alzheimer's disease or neurodegenerative disease is inflammation and oxidative stress. And both these factors play a very major role, and they can trigger formation and accumulation of misfolded proteins, aggregates, and age, of course, comes into this and plays a role. And RAGE is a receptor for age, and usually once age binds to RAGE, this receptor, it triggers more and more inflammation and oxidative stress, as we'll see in a minute. We're not going to go into the details. Maybe we heard it already from the Alzheimer aspect of these things. Just a couple of things for you to, we're going to use the word age and RAGE, and these are the advanced glycation end products, and also RAGE is a receptor for these end products. And when age binds to RAGE, a lot of cascades and issues happen, as we will see in our research what we have done here. So just to give you an idea, just a summary of what I just said, is that if we look at cartoon here, we have age is binding to the receptor RAGE, and you can see, the signaling cascades which can happen. There are different second messengers and so on, like NF-kappa B, TGF-beta, and many others, which lead, as you can see, to a lot of other things like inflammatory cytokines can be increased. You can see COX-2 can be increased. Several TGF-beta itself, several growth factors are reduced, and so on. So why I'm showing you this cartoon is just to give you an idea. It's a complex area, and really we're looking for a needle in a haystack. But anyway, the research looks to be promising, and we can see some results, as I will show you here. The aim of our study was, as I mentioned, there's a significant knowledge gap in understanding the interaction between type 2 diabetes and neurodegeneration. I don't want to say Alzheimer's disease at this stage. Let's just suffice by saying neurodegeneration, because then we want to see different markers for neurodegeneration, and if we can relate these two somehow. We investigated age accumulation in these animals in the brain, RAGE expression, inflammation, oxidative stress in the cortex, hippocampus, and cerebellum. These are especially the cortex and hippocampus, which is very important in case of neurodegeneration. We have done this in diabetic animals, which we injected them streptozotocin so that they become diabetic, and we left them for almost 8 months before we check the different changes. So chronic diabetes in relation to age and RAGE activities. So our methodology was that we had male Western rats, around 250 grams. We inject them with streptozotocin to make them diabetic, and we inject the control ones with saline, and we keep these animals just for 8 months. We observe them for 8 months to see if they become obese, some of them, and so on. At the end of the 8 months, we look for those ones who have fasting blood glucose, which is around 350 to 450 milligrams per deciliter, and then we start to dissect the cortex, hippocampus, and cerebellum from these animals. And our results show, first of all, we want to prove, we want to make sure that the blood sugar levels in these animals is as we expected. We usually took animals which have fasting glucose levels around 300 to 450 milligrams per deciliter. So the aim of this study was, as I mentioned earlier, to investigate the efforts of prolonged diabetes on different regions of the brain by selecting these chronic diabetic animals which have fasting glucose levels between 350 and 450 milligrams per deciliter. And we looked at age accumulation and RAGE, and we can see here age in these animals in the hippocampus is significantly increased, and also in the cerebellum, which is very interesting because these things lead. Now, we also look at RAGE, the receptor 4, which is also significantly increased in the hippocampus, which is most interesting for us at least. But we look at the other regions too, because there might be a generalized effect in all the brain. So the pathological effects, which we can see from these results, which just show you with age, is that these are primarily mediated through their interaction with the receptor, RAGE, and when they bind together, they, as I showed you earlier, they lead to activation of second messenger systems like nuclear factor kappa B, which is a very important transcription factor and is a master regulator of inflammatory cytokines. And when this trio, age, RAGE, and NF-kappa B axis contributes to a lot of chronic inflammation, which is also considered to be a major underlying mechanism in the progression of diabetic complications, which we see also in case of, in addition to the other complications we see in the periphery, also in the case of neurodegenerative changes which are associated with prolonged hyperglycemia. So we investigated to see if, since this trial, it means that there will be a cascade of other inflammatory markers which can be also activated as a result. We look at NF-kappa B, which is a major player here, and as you can see here, it's clearly we have an increase in the nuclear NF-kappa B, which is black. We have it also here in nuclear in the cortex and also in the cerebellum. So it means that definitely there's an activation of NF-kappa B, which means one can expect that other inflammatory markers will be, activated. So our results from this, one can conclude that NF-kappa B is widely, of course, recognized as a master regulator of inflammation, which plays a central role in this transcriptional activation of numerous pro-inflammatory genes, and therefore we went on to look at other inflammatory. We looked at other inflammatory factors to see if they are also upregulated. IL-6 is a major inflammatory marker, and it's very well significantly increased in these animals. In these animals, which indicates to us then there is a lot of other inflammatory markers are activated. We looked also at TNF-alpha. We didn't see in TNF-alpha because TNF-alpha usually you see it at very early stages. You don't see it at very chronic situations. CRP is another very major player, inflammatory marker, and it's very significantly increased in these animals, in the brains of these chronic diabetic animals. So one can conclude from this that our results, they demonstrate that IL-6, which is a very important player in diabetic, in inflammatory chronic diabetes, as you can see, this also has been frequently associated with several neurodegenerative disorders, and IL-6 is considered a potential biomarker for disease progression and prognosis. Also, CRP is a very important inflammatory marker, which also related to neurodegeneration. So it shows us in these animals which have chronic diabetes, we also see inflammatory markers that are also representative of neurodegenerative changes. So we try to see if this is true. We want to see what happens then to the anti-inflammatory markers in these animals. As we can see, IL-10 is a major player in inflammation. Usually it's plays a crucial role in limiting inflammatory response and maintaining immune homeostasis. And as you can see here, is practically very low, significantly low. And this indicates, if it does anything, is that this reduction indicates that the the sustained inflammatory state, which we have seen up to now in these regions, further exacerbates, the vulnerability of the neurons, because the anti-inflammatory markers are not functioning because they are inhibited, and therefore, so we see the situation of excessive inflammation, and most probably there is a degeneration, which we don't know at this stage. So on activation, therefore, of this NF-kappa B, this increases expression of RAGE also, and in turn it increases the activation of different inflammatory markers like interleukin 1B and interleukin 6, as I already showed you. So what we want to know now that we have seen that IL-10 is inhibited, which is an anti-inflammatory, and we know that NF-kappa B, along with several other inflammatory markers, are increased. Therefore, this trio, what they do is that once they're triggered, they trigger an ER stress, and this ER stress causes a problem in the homeostasis, which results into ROS formation, which is a reactive oxygen species, which is a cause of oxidative stress. So we want to see then what happens really in the oxidative stress area, and we look at the major player here, the MDA, and this malonaldehyde, MDA. This is a marker for oxidative stress, and it shows us that MDA also increases in these things, and we want continue to see then what happens to the anti-oxidative stress markers. We can see here that MDA is definitely shows that there is oxidative stress. We look at the anti-oxidative stress markers, and we can see both in the hippocampus and cerebellum they are significantly inhibited. So also catalase is another anti-oxidative stress marker, which is also significantly decreased in the hippocampus, which just the hippocampus is interesting because we see a lot of neurodegeneration in the hippocampus in Alzheimer's disease and many neurodegenerative diseases, and it seems to be more vulnerable compared to the cortex and cerebellum. We look at also another antioxidative stress marker, glutathione, and as you can see also, this is a major antioxidative stress marker, and you can see it's significantly decreased, which means that the oxidative stress is also exacerbated in these animals. So we have inflammation, oxidative stress, which are both very crucial in the case of neurodegeneration also. So then we thought, let's go back and look at cerebral insulin resistance in these brain regions of these prolonged diabetic animals. And we see that IRS1 or the insulin receptor substrate 1 is significantly inhibited, and this is very important along with insulin growth factor. These are crucial components of cellular signaling pathways which are involved in metabolism, and also they are implicated in neurodegeneration and cognitive problems. So this lower level of IRS along with IGF-1 are very crucial in case of neurodegeneration, but also in the case of prolonged diabetes, they are very, as we can see, they are very thin. We went on just to confirm to see if IGF-1 is also decreased in this case, and we found out that yes, IGF-1 is decreased. IGF-1 is extremely important in neurodegeneration because it's one of the first growth factors. In fact, if you consider NGF, IGF-1 is more important in the case of early neurodegeneration. NGF comes, this is from our other studies in neurodegeneration. If you look at neurodegeneration in neurons, just time-wise, usually IGF-1 is lost in those regions where there is neurodegeneration long before the microglia are even activated. So it means IGF-1 is extremely important in neurodegeneration, and also in addition to IGF-1, as I just mentioned, in the case of diabetes, we have another factor, which is the IRS-1, which is also extremely important. So these two factors are really important in neurodegeneration, but they are also very important in the case of diabetes. So we're trying to find see if what are the main common factors between these two things, so that at least we can say, as I said, there's a big gap to understand the mechanisms. So most probably we think that this whole cascade starts with age, rage, which activates NF-kappa B, which activates also inflammatory markers, oxidative markers, and also growth factors. We looked at NGF also, beta NGF, and we see also it's decreased, but I think in this case, beta NGF is not a major player like IGF-1. We try to look also to see if in diabetes to see GLUT1. This is a crucial glucose transporter, which is responsible for facilitating the uptake of glucose into the cells. But we don't see any difference, which means that the system of glucose intake into the brain cells and so on is not affected at all. So then we try to look at some markers for, we try to look for some markers which have to do with Alzheimer's disease, APP, for example. We know these animals, these are normal rats, they cannot produce amyloid beta directly. So what they do is, if there is any kind of neurodegeneration, most probably you see an increase in the APP. And that's what we see here. In these animals, both in the cortex, hippocampus, you can see an elevated or significantly elevated APP, which indicates there is some sort of neurodegeneration going on. Because in these animals, you don't see, you have to have, rats, they don't produce A beta. Normal rats, they don't produce A beta like humans, but the increase in APP and other things indicates that there is neurodegeneration taking place in these animals. We looked also at BACE1, but we don't see much. We see in the cortex it's increased, and BACE1 is the enzyme responsible for the initial cleavage of APP to leading to the production of amyloid beta. But we don't really understand, because you cannot see any A beta. And in the hippocampus, where we have serious degeneration, we don't see any increase of this base. So just to conclude, in this study, we found a significant increase in age, inflammatory cytokines, oxidative stress markers like MDA in these diabetic rats, which suggests there's a heightened neuroinflammation in these animals, and there is cellular damage due to the oxidative stress. Also, APP, which is a key protein involved in the formation of amyloid beta plaques, which are hallmark for Alzheimer's disease, we do see APP is increased, but that's not A beta, so you don't mix that with A beta. We look at also BACE1, which is responsible for initial cleavage of APP. We do see there is increasement only in the cortex, but not in the other regions of the brain. So interestingly, while APP was significantly elevated in the cortex and hippocampus, BACE expression was only significantly increased in the cortex. Most probably it suggests there's a regional differences in the processing of APP and potential for localization neurodegenerative processes in the brain under diabetic conditions. So finally, I think, we do have some indications that in diabetes or prolonged diabetes or chronic diabetes, most probably has some sort of neurodegeneration in the important areas like the hippocampus and the cortex, and to some extent in the cerebellum. Additionally, also the expression of key neurotrophic factors like IGF-1, IRS-1, and beta NGF are seen to be significantly decreased, which indicates that there is some sort of neurodegeneration, which we don't have directly approved for now, which we are working on at the moment. We are trying to see, with immunohistochemistry, looking at very deeply in these different regions to see what kind of neurodegeneration exists there. Also, if you take together these findings, they demonstrate that it's a complex interplay between metabolic disturbances and neurodegeneration in diabetes, underscoring the need for continued research to explore the underlying mechanisms and potential therapeutic targets for mitigating cognitive decline in diabetic individuals. So we hope that maybe we're trying to narrow the gap in trying to see between diabetes and neurodegeneration. I don't want to go to extend it to Alzheimer's disease. And also today we know that several of anti-diabetic drugs are being, clinically in clinical trials. We know metformin already, and we know that GLP-1, and most probably others will also follow. But this indicates that there is some neurodegeneration, and maybe if we really find the proper markers and the proper mechanism, then maybe we'll find a solution for both. Thank you very much.
Thank you for your elegant work, Abdu. The paper is open for discussion, and if there are questions, you can come to the microphone.
The RAGE programs, they actually, there was a RAGE program as a Lyrigon, as a RAGE inhibitor for Alzheimer's, but it didn't work. And so it makes sense as a therapeutic target, but I'm just wondering, mechanism, what could be better?
Well, I think maybe downstream of the RAGE, age-RAGE, interaction, maybe the targets. Sorry. I think most probably could be, and that is a problem because there are several, points where there's still, a confusion between diabetes and, neurodegenerative disease in general. But I think most probably downstream of the age-RAGE combination, most probably we could find the target somewhere there. But at the moment, we don't know exactly. But the growth factors could be one also of a problem which needs to be looked at.
Also, do you have any data about the adaptive immune system and B and T cells in these animals?
No, not at the moment, no.
Any other questions?
Yes,
please.
Thank you. This is not a question, it's a comment. I think when we talk about Alzheimer's and dementias in general, we talk about, not understanding mechanisms. But I think we've got to be more precise. A major part of this is we get ourselves into hot waters with methodologies. It's an area, all the time when I look at research in Alzheimer's, I look at the methodologies and, for a better word, they're still a bit naive. What I mean by that is Alzheimer's is a very, very heterogeneous condition. Even when you talk about genetics, you're talking about almost hundreds of genetic variations. Well, unless someone inherits like presenilin 1 or presenilin 2. Otherwise, it's very heterogeneous. So the point is, when you have so many correlations and you use statistical methodologies, that is the standard one, you won't get very far. What you need to start doing is going backwards. After you've identified, for example, a subgroup in your analysis, like PET scans, biomarkers, you have to go backwards and look at the correlations again. And then to do this, you would have to use a different type of statistics. It's called Bayes statistics. And I hardly see any papers using Bayes statistics with this methodology, because I'll give you another example. If you say I'm looking at someone with cognitive decline, what is the likely chance they are suffering from Alzheimer's? Is a different ball game to saying if someone is being identified as a subgroup with Alzheimer's, what sort of correlates I'm likely to see phenomenologically speaking? So the thing is, you need to change sometimes the statistical methodology to come up with clearer answers to questions that are difficult. I mean, interleukins, cytokines, they go up in almost any situation. If you wake up stressed out, your interleukins and cytokines will go up. And if that goes on chronically, you might end up having, hippocampal atrophy.
Yes, thank you.
So this is not the same as saying, well, this is Alzheimer's. It's an entirely different thing. And
just to correct you there, I never say it is Alzheimer's. I'm talking about neurodegeneration.
no, sorry, I'm not just talking about you. I'm talking about general research in Alzheimer's. And that's why it keeps on being confusing, because nobody talks about methodologies that are incorrect. I mean, we still see p-values of 0.05. If you have PET scans, you ought to, upgrade your p-values to a higher sigma level.
Thank you. I'm afraid we need to move to the next talk. If Dr. Abdu has any other comments. Thank you. Thank you very much.
Our next speaker will be Dr. Per Nielsen from the Karolinska Institute. He will talk on autophagy modulators in clinical studies. Dr. Per Nielsen is an associate professor at the Karolinska Institute in Sweden, where he is working on finding the molecular underpinnings of Alzheimer's disease. He's heading a research group at Division of Neurogeriatrics, where he is also a vice head. Their research is focused on preclinical studies using animal models of Alzheimer's. The research is focused on protein homeostasis and the role of autophagy, which they have shown to play a pivotal role in both amyloid beta and tau metabolism, the two hallmarks of Alzheimer's disease. They are now taking the first step to harness the therapeutic potential of autophagy to treat Alzheimer's pathologies. Please, Per.
Thank you so much, Abdul. Can you hear me out there? Yeah? Okay, great. It's really great to be here. It's first time for me in Abu Dhabi. I'm really impressed by the hospitality, and being a Swede, I can also enjoy actually the warm weather at the moment. So I'm very happy about that. So my group is working on autophagy, which I hope I can convince you is a key cellular mechanism in Alzheimer's disease. Let's go to the first slide here. So basically, Alzheimer's disease is caused by accumulation of proteins, amyloid beta and phosphorylated tau, leading to a lot of downstream effects, including inflammation and eventually neurodegeneration. So this really shows that autophagy can play a role here, because this is a proteinopathy caused by aberrant protein aggregation, and so are many other neurodegenerative diseases. But today we talk about Alzheimer's disease. So we and others have shown quite clear dysfunction of autophagy in Alzheimer's disease brain. This is a human brain section from a late stage Alzheimer's disease showing accumulation of both phosphorylated tau and a protein called P62, which is an adapter for autophagy. So P62 is normally metabolized in the healthy brain. We can never detect it, but when autophagy is interrupted, it starts to accumulate and it gives us a direct sign of impairment. We can also see here how the levels increase in the Alzheimer's disease brain. So this indicates that there is a stop in the flow of autophagy. So this is an autophagosome that contains material to be degraded, and it should fuse with the lysosome where the content should be degraded. But this path is stopped by some reasons, and we need to resolve it. So basically, autophagy is a complex cellular process. It's a cleanup system in the brain, taking care of garbage such as protein aggregates or impaired organelles such as mitochondria. And these autophagosomes, double membrane vesicles, they will eventually fuse the lysosome, as I mentioned, and degrade the content. The system is also very deeply involved in the endosomal system, where it can either link back to the lysosome, or it can also actually lead to secretion of molecules, which is a new role for autophagy in the brain. And autophagy was awarded the Nobel Prize in 2016 to Professor Osumi from Japan. Japan has a strong background in autophagy research, where I did my postdoc, by the way. So, to study Alzheimer's disease, we are using animal models. This is APP knock-in mice. This is kind of updated version of an AD mouse that do not overexpress APP, but thanks to the introduction of familial AD mutations, we can create an A-beta amyloidosis inside the brain. We can see here all these green clumps, which are most of them closely located to the blood vessels, which is also an important aspect. I'll come to that later. But this provides an important tool for us. So we looked into the hippocampus and performed a very basic bulk RNA-seq experiment of these mice, and we found that a large number of genes were altered in. This is a 12-month-old NGF mice having a robust A-beta pathology, as well as neuroinflammation, and etc. And pathway analysis indicated that autophagy is increased in the early stage of the pathology, whereas it kind of decreases and collapses at the later stage. So Makoto, postdoc in the lab, he started to stain some brain sections, looking at a marker of autophagy, which is LC32, and a co-staining with synaptophysin as well as A-beta. I hope you can see it here. Found very significant co-localization, so indicating that things were going wrong close to the synapses. And indeed, synaptosomal fractionation indicated an increase of this LC3 protein as well as P62. Here is the quantification. So it kind of pinpoints that autophagy impairment takes place in the synapses. And this is also what we could see by an electron microscopy analysis. These are synapses in the APP knock-in mice containing a large number of vesicles, and as well we could identify autophagosomes present within the presynaptic vesicles, and this was the first time, so we were very excited about that. We also found a strong accumulation of all these double membrane vesicles autophagosomes in dystrophic neurites, which is very much similar to what has been shown in the Alzheimer's disease brain. So the mouse model recapitulates to some extent the pathologies we see. So this prompted us to look at a little bit more what's going on in the synapses in the brain. So this is a SV2A PET analysis. So this is synapse vesicle 2A. It's bound to vesicles and indicates the number of vesicles in the synapses. And indeed, we found that the signal was increased in many of regions of the brain, including hippocampus, in the NLGF mice compared to control. So this indicates actually that the synapses are impaired. We know that there is synapse loss, but those that are still remaining are very much enlarged and contain increased number of vesicles. So that has implications for SV2A and UCB path, which is about to be developed for Alzheimer's disease. We also found by electrophysiological measurement that these synapses in the NLGF mice, APP knock-in NLGF mice, they have an increased firing rate. We could also take out the CSF from the cisterna magna of these mice and identify increased level of both CSF tau and CSF neurogranin, which is a synaptic marker. So really showing a change at the synapse level. Okay, so we are wanting to know what is really the role of autophagy. So we could show here previously that indeed A-beta amyloidosis could affect autophagy. But what happens if we start manipulating autophagy? And to do that, we have generated a battery of mice which lack autophagy in different brain cells, different subtypes of neurons. For example, here we have CAM kinase 3 mice that lack autophagy in excitatory neurons postnatally, so they have normal development, but after birth, autophagy is deleted. And if you look into the brain of these mice, we see an increase of this P62 protein again. Remember the one I showed you in the human brain tissue in the first slide? And then, of course, we can continue now crossing these mice to pinpoint the exact role of autophagy in the different forms of pathology in Alzheimer's disease. So here's one example where we have crossed into both APP-TG mice. This is all work from my postdoc time, published over 10 years ago. And we have now repeated, so we delete autophagy also in APP knock-in mice. And what is very interesting here is that we see a decrease of the extracellular plaque load as compared to the APP mice. Very surprisingly, we see the same thing in the APP knock-in mice, decreased A-beta plaque load. However, when we start to look into the CA1 pyramidal cell layer here, we could find a very clear increased A-beta intracellularly. So we have here a shift from increased pool of intracellular A-beta, but decreased extracellular plaque load. So that actually links autophagy to a secretory function of A-beta, which is quantified down here. So when we delete autophagy, we have a decrease of 90% of A-beta secretion. I think that's a very important aspect. A lot of attention has been on the extracellular plaque loads, and I think they are important. They cause inflammation, etc. But we should not forget about the intracellular pool of A-beta. Right, so if you look at the performance of these mice, deleting of autophagy and having a robust A-beta pathology, we found that they have a decreased performance in the Morris-Water maze test. Here we have the probe test on day 6, so they show decreased time spent in the quadrant. Also, modified Y-maze test shows a decreased frequency of entering into the novel arm. So this shows really that combination of autophagy deletion and A-beta amyloidosis is detrimental for cognition. And this also translates very well to electrophysiological measurements. This is kinase-induced gamma oscillations. Here we see the background, the wild type signal, which is very robust. Whereas when we remove autophagy, especially in the combination of an A-beta amyloidosis, we see that the amplitude as well as the synchronization of the signal is gone. And here is the quantification. So it really shows that, again, autophagy, deletion, and an A-beta amyloidosis is really bad. Okay, so to study this in more detail, we also develop in vitro cellular systems to trace APP and A-beta processing. So this is a system called retention using selective hooks, RUSH. It's a quite intriguing system where we can use, in this case we have APP, link it to an M-cherry and a C-terminal GFP molecule, and hook it up by streptavidin binding protein down here, which is linked to an ER hook. So that means that we can take APP and it gets hooked up in the ER and then release it by additional biotin in a controlled manner. And thereafter we can trace APP, the fate of APP cleavage and processing. And of course, what is the role of this in the background of autophagy? So here's an example where we now have APP stuck in the ER, and then upon addition of biotin, it releases APP, it travels to Golgi, and then it starts to be either secreted through vesicles or processed and eventually ending up at the plasma membrane. And this is what it looks like in reality. We start to see in the ER, and eventually it starts to be further transported out, and I hope you can see the dots freely circling around in the vesicles, eventually reaching to the plasma membrane. So this is a quite useful system. Of course, we can do then remove. In this case, we do a gene called ATG9. It's a key enzyme for the autophagy pathway. And what we find is that actually the processing of APP is altered, and that is due to a slowered APP processing, slowered APP transport in the cell. So more APP is retained inside the cell. It allows for processing and thereby increases an intracellular A-beta pool. Right, but how about tau? We know that tau is also a key pathology in Alzheimer's disease and an absolute requirement to set the final diagnosis in the post-mortem brain. And we do now the same kind of crossings where we cross, again, ATG7 knockout mouse with either tau 4510 or T2 mouse, which expresses human tau with the P31L mutation, specifically in excitatory neuron. And since our deletion of autophagy is also driven by CAM-kinase 2, so that means that we delete autophagy and express tau in exactly the same cell types, which enable us to pinpoint the effect of autophagy removal on tau pathology as well as tau spreading, because tau is spread transsynaptically through the brain. And this is very fresh and unpublished data from the lab, and that shows that indeed, I hope you can see this now, otherwise you have to believe me, the red here is phosphorylated tau. We can maybe go to this slide is not working, okay. Okay, let's go to this slide instead. To analyze tau, we use sarcosyl fractionation. Here we can separate soluble tau from insoluble tau. And what it shows is that when we delete autophagy, we have a decreased amount of soluble tau compared to the tau mice, whereas the amount of insoluble tau, so sarcosyl soluble, we have a clear increase in insoluble tau compared to the tau mice. And here's the quantification of this. So this really shows that autophagy removal switches the pool of soluble tau towards insoluble tau, most probably because of decreased degradation of tau and increased phosphorylation of tau that remains, so indicating a really important role for autophagy and also tau metabolism. We can take this tau from these tau mice and from the autophagy deficient tau mice and add it to a tau sensor cell line, which pinpoints the aggregation propensity of the tau that we add to these cells. And here we show tau seeding from normal tau mouse, and here we have the signal from autophagy deficient tau brains. And it shows a clear increase in the seeding propensity of this tau. Which most likely links to an increased phosphorylation of tau and protofibril formation of tau. And we could also identify this high molecular weight species of tau in the autophagy deficient mice as compared to control. And these are probably trimers or tetramers of tau forming oligomers, and these are most likely very toxic species. And they also correlate very well with the tendency of aggregation propensity. So the more high molecular weight tau species we have, the higher propensity to aggregate. So there's a correlation here. And when we also now start to look into what's happening in the brain when we have this tau pathology and autophagy deficiency, this is a very rough estimate, but we look at the C1 pyramidal cell layer, and we can see that at 6 months of age, we start to have a significant decrease of the thickness of this pyramidal cell layer, indicating that there is a neurodegeneration ongoing caused by the lack of autophagy and the tau pathology. This is some data from behavioral analysis of the mice, and it also shows that in the open field test, the tau and the autophagy tau mice, they have decreased exploratory behavior, whereas their memory performance is significantly lower when we use the modified YMS test. So it again shows that autophagy plays a role in tau metabolism. When it's removed, it causes this cognitive impairment, and that's very important to know. Great. So let's summarize what I've shown. I hope I convinced you. Autophagy plays a key role in APP processing in A-beta metabolism. When we remove autophagy in a mouse model of A-beta amyloidosis, we increases the intracellular pool of A-beta, whereas the extracellular deposits are decreased, and this is linked to a secretory role of autophagy in secretion. When we look at tau, and this is the recent unpublished data I showed you, removal of autophagy in excitatory neuron increases phosphorylation of tau, increases the seeding propensity, it causes tau to aggregate to form neurofibrillary tangles-like structures. We are looking at those species in more detail at the moment by electron microscopy and other means. So we want to kind of understand what's going on there. And we can also see that this combination of autophagy removal and tau pathology has a direct implication for memory and cognition in the mice. and it also enhances the neurodegeneration that is induced, right? So now we take the next step. Okay, let's, in translational aspects, can we target autophagy to treat Alzheimer's disease pathologies? Because what I've shown you so far is that deletion of autophagy is bad, but how about the opposite? So we turn the pancake upside down, and we look at the effect of clearance mechanism. And the approach we're taking here is that we target both the lymphatic system and autophagy individually and eventually together. Let's see, yeah, it's working. So this is the lymphatic system, which is closely located to the in the perivascular space, and this is a clearance mechanism for the brain where amyloid beta is washed out, especially during our sleep. And as you may remember, I showed you that in our mouse models we have a very strong A-beta amyloidosis going on in the close vicinity of vessels. So we anticipate that boosting the lymphatic system together with boosting the autophagy system will have a potential therapeutic effect on A-beta pathologies and eventually tau. Right. So in the first kind of proof of concept experiments, we have designed a virus which expresses a protein called Beclin-1. Beclin-1 is an upstream autophagy regulator. And here we show the successful expression of Beclin-1 in the hippocampus. And this is very fresh experiments actually that came out last week from the lab. And what we could see is, this slide was not working. Then you have trust me. Here was supposed to be a Western blot data showing a decreased level of phosphorylated tau in the brains of these Beclin-1 expressing mice. However, what we also do now, because we like to do things very properly genetically in the lab, we have generated autophagy activated mice, also again targeting Beclin-1 by introducing a mutation that extends life in previous papers. So we do this in a manner where we activate autophagy slowly, because we know autophagy is a key cellular mechanism. We have to play with it carefully. I think Alzheimer's disease develops over decades, so we need to manipulate the system in a careful way. So we generate two types of mice, one which has a slow activation and one that has a fast activation of autophagy. And eventually we will cross these mice with both A-beta and tau mice and look at the behavior. But this takes a number of years. We just got the mice out of the core facilities, so I hope to come back later on that. Okay, so how about using autophagy in the clinic? So we actually start to see more and more clinical trials using autophagy activating compounds. There are phase 1, phase 2 clinical trials. We summarized it in this very recent review paper. And this is actually some news from the European Medical Agency that approved a compound called blarcamesine that for indication of Alzheimer's, and it's for activation of autophagy. So more and more is happening here in the clinic, and what we are doing together with Professor Mia Kivipelto at Karolinska Institutet is that we look at their finger clinical trials. Maybe you heard finger, so this is lifestyle interventions, and now she's taking the next step to combine lifestyle interventions with different pharmacological interventions, and we are very interested in the combination of metformin that we heard about previous talks. It's an anti-diabetic drug, but it's actually one of the best inducers of autophagy. So we will now have access to this clinical cohort and monitor how autophagy is activated by the metformin, and the combination, of course, with the finger intervention studies. Right, so that's where we are at the moment. This is the group who performed the experiments I've shown you, especially just name some names here: Makoto Shimosawa, PhD student Richard Young, Sophia, Simone, Johanna, Luisa. Yeah, it's a bunch of people here. We collaborate with labs around in Sweden and around the world, and here are the different fundings that support our research. So then by saying that, I say thank you to you for your attention, and I'm ready for your questions.
Any questions?
Yeah, thank you. It's nice presentation, promising for the future. I wonder all the time, there are new reports making relation between migraine and Alzheimer's. And I was all the time thinking that this relation is through the deficiency of autophagy and the lymphatic system. I don't know how you can correlate because those hypersensitive people and they are prone to more stress. They feel the stress more than others. They have more sleep disturbance. They have, I think, is this the relation, do you think? Because we want something practical at the end.
Right, right. Yeah, that's a very interesting question. We haven't looked into migraine specifically. Absolutely. I mean, sleep patterns, clearance during the night is extremely important, which is to a large extent done by the lymphatic system. So I don't know if there is any actually correlation studies of migraine. Migraine can also be intervened in the clinic to some extent if it correlates with AD outcome. That would be very interesting to look at. I will bring that question back to me. Thank you. Yeah.
Thank you. Thank you. Really important data. Have you looked at microglia? It seems to me that microglia are very much must be involved in similar tasks as autophagy, and microglia have been shown to be influenced by the gut bacteria. And I wondered if you've studied your processes in germ-free animals to see what contribution the microbiota might be making.
Important link. The brain is not an isolated organ for sure. Actually, when we start manipulating the blood-brain barrier in these mice, we have a system to generate a partial parasite deficiency in the blood-brain barrier. We have an influx of a number of immunoglobulins, B cells, T cells, potential also bacteria. Absolutely. This causes a very strong inflammatory response. Deletion of autophagy by itself also increases inflammation in the brain. On top of that, microglia has a very active phagocytosis of both A beta and tau, degrades it, but also participates in the spreading of those pathologies. So targeting autophagy pharmacological could probably be beneficial both in terms of targeting the neurons, but also the microglia there, for sure. Mm-hmm.
Excuse me. I just had a quick question. Maybe I missed it, but I mean, do you have markers of autophagy in humans? Are there that we can look at, and is there a correlation between decreased autophagy and increased amyloid production or accumulation?
There start to be markers. We can successfully measure in cerebrospinal fluid at least two markers, LC3, and also not P62, but I think it is actually it's not Becklin, it's Parkin. That can be measured in the cerebrospinal fluid, and they are altered in a way that it correlates with AD pathology. So there are those links as well. And those are actually the markers we're going to use now in this clinical trial to really have a clear outcome of the interventions that is performed in the finger metformin study. So yes, it's coming, but of course nothing in blood yet. So that would be great. What's also missing is a efficient PET ligand to monitor autophagy and protein homeostasis in the brain. That's also on the list.
No questions. Maybe we take a 10 minutes, 15 minutes break. Anyway, let's take a 15-minute break and then we see, or coffee.
Hello. I'm so happy that
very rapidly.
Recording stopped. A coffee shop. I'm not going to say the name of the coffee shop.
I'll introduce our next speaker, Dr.
Recording in
Tarek
progress.
Rashid. The topic will be harnessing the power of big data to understand neurodegenerative diseases. Dr. Rashid is a Kemper and Ethel Marley Chair for Neurology and Senior Vice President at Barrow Neurological Institute. Dr. Rashid earned his medical degree from the Feinberg School of Medicine at Northwestern University in Chicago and his bachelor's degree in molecular biology from Princeton University in New Jersey. He completed his neurology residency and fellowship in movement disorders at Washington University School of Medicine in St. Louis. Dr. Rashid's research focuses on identifying environmental risk factors for Parkinson's disease and other neurodegenerative diseases. He has authored over 180 peer-reviewed publications and served on numerous international review committees and advisory boards. Please, Mr. Dr. Rashid.
This is fine, but I can't see you.
All right. So everybody can hear me, right? All right. Well, first of all, I'd like to thank the organizers for the invitation to speak, in particular Marwan Sabah. I usually start my talks at Barrow by teasing Marwan, but I won't do that out of courtesy to him today. It's always a lot of fun. So I'm going to talk about really a research paradigm that we've been using for almost 20 years now to try to understand Parkinson's disease. So a lot of the work that I'm going to present is based in Parkinson's, and we're sort of newcomers to the ADRD space. And I'll sprinkle out in some of our newer work in ADRD, but I think what you'll see from the talk is how we use these big data methods to study neurodegenerative disease, and how we'll be able to continue to expand into diseases beyond Parkinson's. And these are my disclosures. My work's funded by NIH, DoD, multiple foundations, and I have no personal financial conflict of interest. So we'll start off with an introduction to administrative data, followed by discussing 4 research sort of paradigms, including predictive modeling, geospatial neurology, pharmacoepidemiology, and then just a bit on health services as well. All in an attempt to show how we leverage large administrative data to understand neurologic disease. So first of all, what is big data? Big data is often defined by the 3 B's: the velocity at which the data must be processed to analyze large data sets, the variety of data sets, and you'll see me bring in examples of linking very different kinds of data sets, unique data sets, to understand disease, and then the volume of data that these big data studies use. The studies I'll describe today are primarily in the sort of this in the terabyte range. We're moving into in our lab into data sets that are in the petabyte range, but most of what we're doing can still be done with basically traditional analytic methods. We do some work with AI, but most of it's unnecessary for a lot of what we do. So to understand the studies I'm going to describe, I need to tell you a little bit about Medicare in the United States. So in the United States, for those of you who aren't from the U.S., we only have one national health insurance, and that's for those age 65 and older. Everyone else is in this it couldn't be a more chaotic system of private insurance, public insurance, and uninsured. But in 65 and older, 98% of Americans over age 65 receive their health care through Medicare. We appropriate those data, we purchase those data to study disease, and when we buy the data by the year, it's actually quite expensive. And the data contain the claims that the doctor submits to be paid, or the hospital submit to be paid, as well as demographic data, which age, race, sex. We get ICD-10s and CPT codes, and then we can do some outcome work, especially with respect to survival. We tend to purchase data by primary diagnosis, and a year of Medicare data can cost us as much as $40,000 for our data sets. And we've accumulated about $1.5 to $2 million worth of Medicare data in the last 15 years. We also the data are de-identified, but we can get down to what we call in the US the ZIP9 level, which is a pretty fine geographic level. It doesn't get down to the house, as you can imagine, for privacy purposes. But you'll see examples of how we take the geospatial coordinates that we can derive from these files to get down to a geographic level that can help us really get pretty fine resolution exposure mapping for health exposures. And then we do a variety of studies, including descriptive epi, spatial epidemiology, health services, and disease outcome work. Oops. Oh, that's good. It's very pale here. It's better up there. So we have a number of data sets in the lab, and the bottom half of the slide are all brand new data sets that we've either just received or are receiving. The two at the top I'll talk about, that I'll refer to mostly for this talk, are as a case control study for Parkinson's disease from 2009 with 100,000 PD cases and 800,000 controls. A newer data set, which I'll describe in a couple studies, with 300,000 Parkinson's disease cases, 4.5 million controls. And then one of the data sets that's actually very relevant for this audience is a data set that we anticipate receiving in about 6 weeks, which is a study of about 50,000 frontotemporal dementia cases and 900,000 controls. As you can see, the numbers that we're talking about with these studies are quite large, and the interest in using big data sets to understand neurologic disease really came out of the need to increase sample size to be able to improve power to identify novel risk factors for Parkinson's. Okay. There we go. So I have to have a slide that sort of describes the three diseases that we'll talk about a bit today. Obviously, Alzheimer's, the audience is all very familiar with. Most common of the neurodegenerative diseases. Most of my work focuses on Parkinson's disease. About a fifth as common as Alzheimer's. And then we have some work that I'll present briefly on ALS as well. Much less common, much rarer. But the reason I'm going to present an ALS study because of the approach we took to understand, to identify potential disease-modifying medications that could be repurposed from the Medicare formulary. The rationale, though, for really talking about all three in the same talk is there are likely common pathogenic mechanisms, and I'll present some examples of that in a minute, and including things like inflammation, discussions we've had already today about vascular contributions of dementia are probably relevant across all three diseases. So give you an example of prediction from a study that we published back in 2017. So there's been a long-standing interest in identifying people with Parkinson's disease during the prodromal period, and for the most part, Alzheimer's is way ahead of us in terms of the biomarker development and the ability to because of the frequency of the disease, it's very easy to develop prodromal cohorts of AD, but in Parkinson's, it's actually much more difficult. So for a variety of reasons, we became interested in identifying people with Parkinson's before they were diagnosed. And so for this particular study, we used a study of 90,000 incident Parkinson's patients identified in 2009 in Medicare from their ICD-10 codes, and then 120,000 controls. And then we took all their CPT codes and all their ICD-9 codes, and this was ICD-9 at this time, put it in a penalized regression model, and we looked for, and we tried to develop a predictive model using those codes to identify people using older codes that occurred prior to their diagnosis. And so what you see in the top middle is a histogram of the predicted probability that a particular beneficiary would be diagnosed with Parkinson's disease. And on the left, you see the controls, and on the right, you see the PD patients, with a predictive model that included age, race, sex, anosmia, constipation, and REM sleep behavior disorder. And you see there's some separation of these histograms, but for the most part, they sit on top of each other pretty closely. And I think the AUC for this was like about 0.6. So didn't perform very well. But when we threw in all the ICD-10 and CPT codes, we ended up with the predictive model on the right. And you see that the AUC for this predictive model, all from codes that were used prior to the diagnosis, was 0.86. This particular model is overly complex, has 536 predictors, but it's sort of proof of principle that we can identify people from claims data only in their prodromal window. And this was work that was done at the time by Mark Warden and Susan Nielsen. We've subsequently done this with ICD-10, very, very similar kind of performance, and we've got new studies following this particular approach. What's interesting about these codes, though, is they really give you a window into what's happening in the prodromal period in Parkinson's disease. And in this graphic, we sort of very simply collapse some of the variables into descriptive variables to understand what that course looks like. And about 3 years prior to diagnosis, you start to see codes for fatigue. 2 to 3 years prior to diagnosis, you see skin changes, some psychiatric symptoms, and then autonomic symptoms. 1 to 2 years prior to diagnosis, you start to see cognitive impairment, trauma, and I'll come back to trauma in a few minutes. And then we see this massive uptick in diagnostic testing. These patients are going to the doctor doesn't know what's going on, so they just order. In America, we get tests very freely. They get EMGs and EEGs, MRIs. The range of tests that are ordered because of what we in the lab call the flail, where people don't know what's going on, but they know something's wrong with the patient, leads to a tremendous amount of healthcare expenditures in the United States. Start to see motor symptoms gain imbalance, and then they are diagnosed with Parkinson's. So really nice recapitulation of what we know is happening, what we know clinically happens in this window, just from the ICD codes alone. Another area that we've been using Medicare data that has actually become really one of our signature research methodologies is geospatial neurology. And this is work that's largely now led by Dr. Brittany Kurzanowski in the lab. The first work we did on this, and I'm going to show many examples of this, and it's going to relate back to ADRD too, was led by one of my early fellows, Allison Willis, who's now at Penn. So Alice asked the very simple question: is Parkinson's disease in the United States non-randomly distributed in the United States? Because believe it or not, at this point, this is published in 2010, nobody had ever actually done the study to say what is the distribution of Parkinson's in the United States, with the idea being if it's non-randomly distributed, it might provide clues into environmental risk factors that in certain areas of the country. And so what Allison showed, this is an age, race, sex standardized incidence map at the county level. So this is a cruder level that we do now. And in the areas of red, the incidence of Parkinson's is tenfold greater than the areas in green. So, and you see that there's this strong clustering in the Midwestern and sort of southern United States, going down through the Ohio River Valley and into the Mississippi River Valley. And to date, I think this is one of the strongest pieces of evidence of important environmental triggers for Parkinson's. We just don't understand what those are exactly, although we're doing work currently to really try to understand how this geospatial pattern contributes to our understanding of what causes Parkinson's. So Brittany featured on the top. This is a study that's published last year, where we looked at the relationship between Parkinson's disease risk and air pollution in a study of this was also 100. This is a study from 2009 as well. 100,000, about 90,000 Parkinson's disease patients. We used the base file, so 22 million controls. And on the left, you see a map that with these areas in red. This is what we call a BIALISA. It's a adjusted correlation map. And areas in red correspond to the areas with the highest incidence of Parkinson's and the highest measured levels of particulate matter less than 2.5 microns, which is the particulate matter, the form of air pollution. It's the most toxic to the body and the brain. And so once again, this area through the Ohio River Valley, Midwest, down into the Mississippi River Valley, really lights up as being most strongly associated with air pollution. So we think that map that I showed you previously, in some part, is explained by the air pollution levels in those areas of the country. On the right, it's maybe a little bit faint. You can see the nationwide data at the individual level, looking on the x-axis, the average county level particulate matter in a window that was a decade before onset of disease, and the y-axis the relative risk of Parkinson's at that county level. And you see what we found is a pretty much a linear dose-response relationship up to about 14 micrometers cubed of PM2.5, and then it sort of levels off a bit. But what's interesting is the national air quality standards for particulate matter in the United States were recently lowered to 9, but we see a dose response relation well below that, suggesting that even at the lower air quality standards that we put in force a couple of years ago, we still see Parkinson's disease is related to, or air pollution contributes to the risk of Parkinson's disease. So we're also interested in how air pollution contributes to other neurodegenerative diseases. And so this work was just presented at AAN by Michelle Harner and Brittany Krasnowski again, looked at traffic-related air pollution in the United States and Alzheimer's risk. And we once again see a relatively linear dose-response relation between Alzheimer's risk and traffic-related air pollution. Now, this is a subset of the particulate matter. Other contributors are things like emissions from factories and dust in the Midwest. In the Southwest, we have particulate matter. A lot of particulate matter comes from just dust from the desert. But just the traffic-related component alone is linearly associated with Alzheimer's risk. There's pretty strong evidence of PM2.5 and Alzheimer's risk already. We were going deeper into try to understand that. And then what you see on the right is a map of the United States with the 3 cities where you see the highest levels of dementia and the highest level of traffic-related air pollution. So these are the 3 cities, this is St. Louis, New York, and Boston, where if you were to mitigate traffic-related air pollution exposures, you would have the greatest impact on Alzheimer's risk. We can also, and this is just a quick slide just to talk about other kinds of exposures. Brittany's done work with trichloroethylene, which is a neurotoxicant that's been very a hot topic in the Parkinson's field. With TCE, we see once again a dose response relation between this is airborne TCE and Parkinson's risk. But what I really want to show you is on the right, we can actually, with some of the methods we're using, get down to the individual point sources and then map the risk of Parkinson's or any disease for that matter out from those point sources. This is a facility in Oregon that has a particularly high risk of Parkinson's emanating out from it. This is a TCE emitting facility. So we can literally do this with any of the 500 neurotoxicants in the National Toxic database. So these are just scratches the surface of the power of the kinds of tools we're using these days. And then back to dementia. George Carway, a postdoc in my lab, recently has had this paper accepted in Alzheimer's and dementia, looking at the role of cardiometabolic disease in dementia risk. So this is coming back to some of the earlier presentations that were made today. In this particular study, we looked at 700,000 incident dementia cases. This is all-cause dementia in the United States, and then looked at the portion of the cases at the, and this is at the zip code level, that are due to one of 8 cardiometabolic diseases like congestive heart failure, acute MI, diabetes, etc. And we actually can, and what you see on the left is that same heat map approach where we look at the areas where you see high cardiometabolic disease burden and high dementia, all-cause dementia risk burden. And once again, it's in the southern part of the United States, but also just heavily right over the stroke belt in the United States, an area that is known to have a very high risk of stroke. On the right, we have what's called a population attributable fraction map, where at this very fine geospatial level, we can calculate the population attributable fraction of dementia that's due to these cardiometabolic diseases. And in areas in red, up to 60% of cases of dementia can be attributed to some form of cardiometabolic disease. So this once again gets at a very important public health message of if you were to target public health interventions in the United States toward certain areas of the country, reducing cardiometabolic disease in those areas would have a substantial impact on the burden of all-cause dementia. And then finally, we've recently done a little bit of work with frontotemporal dementia. This is work for one of my medical students, Nishant Satapathy and Jordan Killian in my lab. And so on the left, you see a standardized incidence ratio map of frontotemporal dementia. And you see in this particular case, the geospatial pattern is very different than it is in Alzheimer's and all-cause dementia or in Parkinson's. You see these very spotty areas of red. The areas of red are the highest incidence of FTD, and you see really interesting patterns in sort of Southern Oregon, Northern California, some patches through the Midwest, and so we're really in the very early stages of following up on these on this work and trying to understand what those environmental factors are that are likely contributing to disease in some of those areas. Other areas, there's probably some other explanations like specialty centers that maybe tend to diagnose cases a bit more. But in many of these parts of the country, these are rural areas, and there's likely some very important signals here to follow up on. To show you a couple examples of some work we're doing around pharmacoepidemiology, and in these studies, we're primarily focusing on trying to identify medications that could be repurposed to treat neurodegenerative diseases and slow progression. And we've published probably 15 studies using various pharmacoepi methods. This paper by Ija Song, published a couple years ago, looked, instead of at individual medicines, we lumped medications by their primary and secondary target, their target biologic targets. And then we asked the question, well, medications that lower the risk of Parkinson's, Alzheimer's, and ALS would be particularly interesting, knowing that there probably are some common mechanisms of these diseases. And so what we found that was really particularly interesting is that what I think we're probably most excited about is if you look at the xanthine dehydrogenase blocker, allopurinol, it lowers the risk of all three diseases significantly. And one of the things that's super interesting is that there's a medicine on the bottom, a class called the vascular endothelial growth factor A target. The medicines that target that particular action pair. Carvedilol was one of the medications in that category. It has an off-target mechanism also for xanthine dehydrogenase as well. So carvedilol is probably actually popping up because of its secondary mechanism in xanthine dehydrogenase. So these data can provide really powerful ways of sifting through thousands of medications to identify medications that potentially could be repurposed. We've done this. We used a really unique approach in ALS that I'm excited about, because I think this is probably part of the way forward in how we validate some of the findings that come out of the Medicare data. This is work done by Susan Nielsen again and Colin Kreppel, who's now at the University of Wisconsin. And in this particular study, we use a smaller data set of 1,000 people with ALS, 170,000 controls, looked at medications associated with a lower risk of ALS through a complicated discovery process. We landed on 4 drugs that we would then put into the SOD1 mouse model of ALS, and of those, lovastatin proved to delay the onset of weakness in the mice, prolong survival, reduce activated microglia, and also delayed motor neuron loss in the mice. This has led to a Department of Defense grant that we're working on currently to look at broadly across all cholesterol-lowering medications, and so stay tuned on that. But in this case, we went from bedside to bench with the hope that we will then take these findings back into humans. And I'll just end with a couple examples of the way we use administrative health data to understand health services utilization. Once again, work done by Allison Willis when she was in the lab. And this is a combination of a couple different papers that she published when she was in the lab. On the left, Allison asked the question, does neurologist care impact the survival of people who are newly diagnosed Parkinson's disease? And believe it or not, had never been looked at. And what Allison found was that the 5-year survival of people who with Parkinson's disease who saw a neurologist at least once, it only had to be once for us to see this effect, was the survival was 22% greater than the people who saw a primary care doctor only. To date, this is probably one of the most this is the strongest neuroprotective signal we have in Parkinson's disease, yet we don't think of this as neuroprotective. But there's something about what these neurologists are doing in the care of patients that is improving their survival. She asked the question, well, what might that be? On the right, you see another paper that we published in Neurology, and we looked at hospitalizations for neurodegenerative disease, diagnoses, psychosis, depression, urinary tract infection, and traumatic injury. And what we found is that for psychosis, depression, UTI, and traumatic injury, we saw a dose-dependent reduction in hospitalizations for those indications if you saw a neurologist. So the more you saw a neurologist, the fewer admissions you saw for those sort of chronic complications of Parkinson's disease. And these are all people who were incident diagnosed and followed forward. So they're all the same duration of disease. And I think this may be my last slide. Alejandro Camacho Soto, my lab, is a physiatrist who's particularly interested in traumatic in falls, fractures, and traumatic brain injury. And Alejandro looked at the risk of traumatic brain, the risk of Parkinson's disease in relation to traumatic brain injury in the 5-year window prior to diagnosis. And on the left, you see a survival curve. The red is people with Parkinson's disease, and on the far right is when they're diagnosed with Parkinson's, and the left is 5 years prior to diagnosis. And you see from the beginning of the study period, which is where we follow people back 5 years, you see a separation between the lines. But then in that year prior to diagnosis, you see just this massive uptick in traumatic brain injury occurring as people approach their incident diagnosis date. We actually use this to argue that TBI, at least in this window, is not likely causally related to Parkinson's, but instead is related to the prodromal symptoms. And on the right, you see sort of a flip version of the same sort of thing. On the far left, on the x-axis, is when people are diagnosed, and then we follow people. If you look, we go back up to 6 years in our models, and we look at the risk of fracture occurring in that window, and you see that the risk of fracture separates from the controls into people who are going to get Parkinson's disease as far as 6 years back. So people are starting to develop PD-related morbidity up to 6 years prior to diagnosis, and we can see this just in simple claims data. So this is my lab, and some of Marwan's people too. During our holiday Christmas party, this is where we practice at where we do our research at the Barrow Neuroanalytics Center. I'm very happy to take any questions in my minute and 16 seconds left.
Thank you very much. Have you looked at education and poverty?
So education is tricky because honestly, poverty we can do better because we don't have individual level data on those. So we can only poverty we look at poverty using various geographic variables like ADI or neighborhoods SES. But education is tricky. It does track with SES and neighborhoods. Like if you live in a rich neighborhood, obviously education levels are generally higher, but we do lack that level of information. We can see though in our Alzheimer's data using neighborhood levels of education, meaning if you live in a richer neighborhood, which is basically SES based, we can see a protective effect of neighborhood on AD risk.
Just a comment. I think that it's a dirty little secret. Every single environmental risk factor for Alzheimer's is more common in poor people. And if we wanted to do something about it, just increasing education would be the most valuable thing that could possibly be done.
Yeah, it gets very muddled together, as you can imagine. The poor neighborhoods are where you have less education and less food security, but you also have the most air pollution because that's where the factories are often located. So it does get all muddled together. We do address those in our models, of course, to the extent that we can.
Yeah, thank you very much for the presentation. I think it's really amazing to use big data for these kind of predictions. I have some comments. So the first one is, did you try to do a kind of external validation to these risk prediction models that you developed? Why I'm saying this is I'm a little bit, I don't know, when I saw over 500 predictors for your model providing an AUC of 0.86. So I'm thinking about generalizability. So, there are some other models that can provide the same AUC and even calibration with fewer predictors. So this is the first, the first question. And the second question is, from clinical practice, we would be happy to use these risk prediction models for personalized medicine, so for predicting the incidence of Parkinson's disease for anyone. But with over 500 predictors, and I suppose there are a lot of missing data on these, how in practice one can do that? Thank you.
Yeah, so I think those are related, and jet lag will prevent me from remembering two questions, so I'm going to just blend it into one. So that was proof of principle. We recognize a model with 500 predictors is not practically useful, but keep in mind that the models that people have developed for PD have used data that was acquired at the time people are diagnosed. What's unique about what we're doing is we're using data from before they're diagnosed. We don't know how to identify people with Parkinson's before they're diagnosed, so this uses codes from that prodromal period. The newer version with ICD-10, we just use only ICD-10 based ICD-10 codes, not CPTs or other codes, and that model has fewer codes. But our current plan is actually to run that model in our electronic health system within our medical system, and then actually confirm what we see in that pared down model. But you're right, the model that I presented is not practical, but it's a proof of principle.
You mentioned AI, and you said that it may be overused. I just wanted you to elaborate on that.
Not overused. It's often not necessary. So we developed a machine learning model using random forest machine learning, using the same data set, and we get a similar AUC. But penalized regression model works just fine for this size data set. If you get into much larger data sets, if you're going to incorporate things like image, like the way people move and things like that, that would be where AI clearly would be needed. So it's just that people sort of AI is sexy, but often you can do it with data. So that was the one point.
Thank you for this wonderful talk. Hanan from Cleveland Clinic. I would like to know, were you able to find SABV data for, non-agnostic, sex-specific data when you segregate to see women's environmental versus other factors in your big data?
So I think I understand your question. So we do run stratified models, and we don't find really that much difference in the pollutants we've studied so far. But that isn't to say that there aren't logical pollutants that might actually impact one sex more than the other. We haven't really done that yet, but I'd say we're sort of at the cutting edge of what people are doing with these large methods. The geospatial methods we're using have never really been applied in neurodegenerative diseases, so we're really at the beginning of this work, and so I think that in a year or two from now, I can probably answer that question much more specifically. Yeah.
I think we should continue to the last speaker. Dr. Friedland is a clinical and research neurologist devoted to the study of brain disorders associated with aging. He is a graduate of the City College of New York and received his MD degree from the Mount Sinai School of Medicine in New York in 1973. He completed his neurology residency at the Mount Sinai Hospital and was a fellow in dementia and aging at the Albert Einstein College of Medicine, New York, with Robert Kassman. He then worked at the University of California, Davis, and in the research medicine group of the Lawrence Berkeley Laboratory of the University of California. He is currently on sabbatical leave in Kyoto, Japan, as a long-term invitational fellow, supported by a grant from the Japan Society for the Promotion of Science. He is working with collaborators at the Kyoto Prefectural University of Medicine and the Kyoto Institute of Technology on the influence of the microbiota on the development of neurodegeneration in transgenic Drosophila. Yes. His topic will be the role of bacterial amyloid in neurodegeneration. Please.
Thank you very much, Dr. Adam. I'm very pleased to talk to you about my ideas and work in regard to a possible initiating factor for Alzheimer's, Parkinson's, and ALS. And I can't go on without thanking again Dr. Sabah and Dr. Adam and their team for their important work in bringing this conference together, where we can all meet. And I start this way to be sure I cover this, because sometimes things become rushed in the end of a talk. This is my group I collaborate with at the University of Louisville and others in Japan, Luxembourg, and the United Kingdom. I'm grateful for the previous support I've received, as well as the current support, particularly a mini sabbatical from the Luxembourg National Research Fund. And I'd like you all to imagine and consider, how is it we ask questions? How deeply do we inquire? Do we settle for an answer which is superficial and maybe not sufficient? Also, what does it mean to know something? And here I'm not talking philosophically. I'm not going to give a lecture about epistemology. I wouldn't really know what that means. But just on our neurological, for a neurologist, what does it mean when we know something? And the main question we have is here, what is the cause of Alzheimer's, Parkinson's, and ALS in most cases that don't have a causative gene? Even ApoE4 homozygous. I wouldn't call it causative, because there are patients who survive the late ages with those genes without disease. This is illustrated perhaps obviously in my opinion. Colin Masters said, he's a very distinguished neuroscientist. He said, the etiology of Alzheimer's is clear. The proximal cause is the accumulation of A beta. And I think this is rather superficial thinking. We all know many older persons have this in the brain and they're not impaired. To say that they would have gotten impaired if they lived long enough is kind of like arguing about how many angels can dance on the head of a pin. We don't know. We know that the amount of A beta you have in the brain is not related to how demented, impaired you are. Consider this patient with a subdural hematoma. Is it correct to say the cause of this was bleeding? Obviously, bleeding is involved in this disease in this person, but if he was hit over the head by a baseball bat, that's more causative than the bleeding. The bleeding is a mechanism. The baseball bat injury is the cause. Consider this in regarding ALS. We all know the first symptom can be in the foot, in the hand, in the tongue, or somewhere else, but weakness of the foot, falling, or difficulty with speech, dysarthria. What is the cause of the different onset? And I'm open to all suggestions. As far as I know, there's no proper or popular theory about that, except for the possibility that the various forms of ALS are caused by where are the microbiota interacting with the nervous system. So a problem in the colon may affect the cord. A problem in the mouth might affect the brainstem. So where the interaction occurs. And there is significant evidence I'm going to show about the role of bacteria in brain diseases, particularly neurodegeneration. And there's a particular form of bacteria that may be involved. What I think is not generally recognized is part of our physical reserve is the microbiota, and this is our largest environmental exposure. That we all have 1/2 to 1 kilogram of living organisms inside, in the gut, but also on the skin, the mouth, the nose, the lungs, and so on. And this is our lifelong exposure. It was there 1 billion years ago in all our ancestors. They evolved with us and we evolved with them, and they influence our health. An example of asking questions is to consider Alzheimer. His dissertation, Würzburg, 1888, was on Ohrenschmalzdrüsen, which is stressing my German, but that means earwax or earwax glands. And even today, the bacteria that live in the ear have not been well studied. And there is an acoustic branch of the vagus nerve that innervates the orange part of this external ear. Nobody has considered, as far as I could tell, how this aspect of the vagus could influence brain disorders. We all know now there's significant evidence that the vagus nerve from the gut is a pathway for amyloid and amyloid-like products to be delivered to the brain, which is thought to be related to Parkinson's, particularly since the dorsal motor nucleus of the vagus nerve is the neurons of origin of this nerve that innervates the gut. And that is thought to be the first area pathologically affected in Parkinson's disease, in the medulla. So about 1922, or about 15 years ago, I was wondering that we know the amyloid proteins for Alzheimer's, Parkinson's, and ALS are infectious or transmissible, or perhaps prion-like, or perhaps, according to Prusner, they're prions. So if that can happen, if one molecule can change another molecule, what about in the environment? Is there any similar molecule that through molecular mimicry could induce this effect? And I found that it was discovered in 2001 by Matthew Chapman in Michigan that bacteria make extracellular amyloid proteins. All of these bacteria shown on the left, which are many of our most popular or most abundant organisms in our body. They have remarkable features. They look like amyloid. They are amyloids. They look like our amyloids. And they're functional. so they're important for the bacteria. So I developed two hypotheses. One involving the bacterial amyloid proteins can cross-seed the amyloid folding of neuronal proteins. And also, that the innate immune system recognizes these by TLR2, also SRD1, NF-kappa B, and INOS, and CD14, and that this is the similar pathway by which the immune system, the innate immune system, recognizes the amyloid proteins. And thus, the appearance of these proteins to the brain may be perceived by the pathogenic protein recognizing systems to be bacterial products. So we exposed aged rats to these proteins and found that Curly exposure, Curly is the most popular, most widely studied bacterial amyloid. Curly exposure enhanced microgliosis. So the microglia were activated by exposure to bacterial amyloid compared to animals who were exposed to identical bacteria, but genetically lacking the ability to make the pathogenic protein. We published this in scientific reports. And perhaps I can get to it later, but there's not a recognition in the scientific community about new areas, at least when it's been distressing to me to see papers written about immunological function in Alzheimer's, and this is not discussed. There's considerable other evidence in this regard. A beta and alpha-synuclein can act as seeds and change aggregation pathways. And Curly and other bacterial amyloids have been shown to influence aggregation of neuronal proteins such as alpha-synuclein in vitro. Seeds of alpha-synuclein can cause the misfolding of tau. And Lundmark showed that Curly from E. coli can trigger amyloidosis for serum amyloid A. Hard to ignore is a paper from Westermark from Sweden that eating pâté de foie gras triggers serum amyloid A amyloidosis in mice. Because the protein is there in the liver of the duck, and when you eat it, you absorb some of the amyloid, and it causes cross-seeding of the amyloid present in the animal through dietary exposure. Also, Masmanian and Sampson showed that the bacterial amyloid I'm talking about, Curly, enhances alpha-synuclein aggregation as well as motor impairment. More so, as shown on the right, treatment with EGCG, which is a very potent flavonoid found in green tea and other products, diminishes this. And EGCG impairs amyloid production by bacteria. We don't have a good assay about how much bacterial amyloid is present, but they recently was shown to be more E. coli in the LRRK2 risk variant for Parkinson's disease. And in this paper, E. coli administration triggered alpha-synuclein in the colon, and E. coli is a large producer of Curly or bacterial amyloid. In regard to ALS, with the assistance of my postdoc and technician here, shown here, we exposed G93A ALS model SRD1 mice to Curly with a control group exposed to identical bacteria lacking the ability to make Curly. These animals get hind limb paralysis around 6 to 7 months and 50% survival at 9 to 10 months. And the bacterial amyloid we used was Curly, also called CSGA. We measured their motor function with a computerized treadmill. And as a neurologist, it's kind of incredible to say that one of the main findings was the mice developed a wide base gait, because that's something neurologist does every day to evaluate the base of the gait. I never thought I'd be doing that in mice. But the red line here for males particularly showed that Curly causes increased width of the gait of the animals, exposure to Curly compared to the other animals. And the Curly-fed animals declined more rapidly. The Curly-fed animals of these ALS model animals had changes impaired function on the tread scan, the computerized treadmill. They had more skeletal muscle staining. They had more autophagy and more skeletal muscle, TNF alpha, and increased astrogliosis in the brainstem. Some other things that have been happening in this field include that these biofilm-associated proteins in bacteria is related to Parkinson's, so that is Parkinson patients have been reported to have more of these genes in their intestinal bacteria. And these functional bacterial amyloids have been demonstrated to induce alpha-synuclein aggregation. If you inoculate these fibrils from functional bacterial amyloids into the brain, you can promote Parkinson pathology. This evidence is summarized here, showing other reasons why the functional bacterial amyloids can be involved in degeneration. And as you see, this involves aged rats and nematodes, alpha-synuclein overexpressing mice, Parkinson patients, and other forms of mice. At the moment, I'm investigating this in Luxembourg with Paul Wilms, who has shown in his research that the combination of low fiber intake as well as exposure to Curly is particularly effective in alpha-synuclein overexpressing animals. And I think I will be ending early in regard to helping everybody get to dinner, which we all are anticipating. But in regard to asking the right question, I have come upon these two quotations, which I think are particularly valuable for all of us. First of all, Claude Bernard, who was a French physiologist around 1876, a friend of Louis Pasteur, he wrote a book, Introduction to Experimental Medicine, which explains how he discovered glucagon and how he devised experiments, and when they failed, he was happy because he learned something. I'm afraid some people I've worked with at NIH and elsewhere were too afraid or too hesitant or too humiliated by the idea that humiliated by the reality that they might have an idea which turns out to be wrong. So what Bernard is saying, that theories are not true or false. They are fertile or sterile. So my favorite example of that is Christopher Columbus, who had a thought that if he sailed west, he would get to Asia. And he was wrong, but it was a rather fertile discovery. The other one is Paul Feyerabend, who is a philosopher of science at Berkeley. He wrote an important book, Against Method, where he says no theory fits all the facts in its domain. So I think when we consider something, we shouldn't think, well, do we know enough to know this is right or to know it's wrong? Because any particular new important theory or new idea must be contradicted by other facts. Otherwise, somebody would have already thought of it. So when Copernicus said, and Galileo, the Earth revolves around the sun because of this and this and this, people didn't go, oh, of course, why didn't? Of course, you're right, of course. Because there were reasons to believe he was wrong. When Randy Marshall in the 50s or 60s said peptic ulcer is caused by bacteria, people were not willing to look at his data, and I believe he lost a grant, may have got fired. People thought he was dumb because he didn't know that bacteria don't grow in the stomach. It turns out that they do. I learned that they don't in school, and I was wrong. So part of the reason I'm so interested in these ideas concerning questioning and thinking is I published this book in February this year, 99 Lessons in Critical Thinking. And I'm not presenting any magical theory about how to think critically, other than to ask questions, continue to ask questions, and never stop asking questions. Finally, Louis Pasteur said, "Let me tell you the secret that has led me to my goal. My strength lies solely in my tenacity." This is a rather remarkable statement because he developed a vaccine for cholera and anthrax and rabies. He discovered stereochemistry. He discovered the biological basis of fermentation. So when I was in college and medical school, I thought I can't do research because I'm not smart enough to do research. But actually, what's required is not brilliance, but it's having an open mind, and particularly having the ability to do hard work. Tenacity is a determination to continue what you are doing, continued effort to do or achieve something, even when this is difficult. And in regard to tenacity, I want to thank Dr. Sabah, Dr. Adam, and his group for their tenacity, which was incredibly required in order to make this meeting a success. To summarize, otherwise, I would like people to have an open mind to consider things that appear to be wrong. Things that appear to be wrong could very well be wrong. The evidence that something is wrong could mean that your idea is wrong. It could mean that it's false. The thing that implies that your idea is wrong may be false. And if you have an open mind to that, you can be perhaps more productive, more efficient, and more able to develop effective mechanisms to deal with these horrible diseases. Thank you very much. Now I'm happy to answer your questions.
Questions? Mr. Friedland?
Mr. Friedland, a fascinating talk. I have two questions. One having to do with if this is sort of a prion activity that you're describing, the bacterial amyloids can activate other proteins to become amyloid. Does it work sort of in trans? There are over 400 different amyloids in the body. A beta 42 is just one of them in the brain. We also know there's light chain. There's AL amyloid, there's transthyretin amyloid, there are AA amyloid that you said. So do these gut bacteria activate or have the ability to seed all amyloids? Are there different curlies that are specific for different amyloids? How do you think about that?
Thank you very much for that wonderful question. That's exactly what I anticipate, but it has not been effectively or efficiently studied. And I don't know why there aren't more people willing to work on this. Just one further anecdote. Our paper on ALS and these bacterial amyloids has been cited only by a few